My name is Adelola.
My name is Laurence Levy.
I'm a professor of neurological surgery at the University of Ibadan in Nigeria, and the chief consultant to the teaching hospital also at Ibadan. And it is my privilege to be talking today to Professor Laurence Levy of Zimbabwe, the doyen of neurosurgery in Africa, and one of the leaders of the discipline in the world. Professor Levy does not like to talk much about himself, but we are fortunate that we have some information about him, and I will share this with my audience before we listen to him to expatiate on some aspects of his total and global experience in neurosurgery in Africa, which has spanned not less than 30 years. Professor Levy came to Rhodesia, now Zimbabwe, in 1956. I'm reading aspects of our writings on him from this book. And he qualified from the UCH London in 1945, and he traveled far and wide in search of neurological surgical training. He studied neuroanatomy under Professor J.C.B. Grant of Toronto and served his neurosurgical apprenticeship, first under Wilder Penfield of the Montreal Neurological Institute, then under T.I. Hoen of the New York Postgraduate Hospital and Bellevue Hospital. And later he came to England and worked with the late Douglas Northfield at the London Hospital in Whitechapel. He came to Africa, as I said, in 1956, and he was not only a neurosurgeon, he chairmaned the Department of Surgery, and he was professor and head of that department since 1971. We are fortunate to be with him today. We came years after him. He's been the leader of neurosurgery in Africa, and he graciously accepted to host the Pan-African Association of Neurological Sciences meeting in Harare this year. And it has been a wonderfully successful meeting, academically, scientifically, socially, and it's really a tribute to his leadership that this meeting has come off so magnificently. It's my pleasure to be talking to him. I haven't had this opportunity, and we'd now like to listen to him. He will tell us a little bit about himself and about the problems of neurosurgery in Africa. Professor Levy, will you please just tell us something about your background, why you went into medicine and
well, I was Adelola, I was born in United Kingdom and went to school there. And when I was about 16, I was looking, as my elder son is looking now, at veterinary surgery. And somehow or other, I think under my mother's influence, I changed about that time and decided to do medicine instead. My mother's granduncle had been a very famous anatomist, and I think that she thought that her son should be the same. I went to medical school there in the United Kingdom, and then served His Majesty for 3 years in the Royal Air Force, and then went for training with J.C.B. Grant. That time I was still thinking that perhaps anatomy was what I should do, but I became particularly interested in neuroanatomy while I was there, and then moved up to Montreal, where I immediately fell under the spell of Wilder Penfield, as everybody who met him did, And this is what finally moved me away from anatomy into neurological surgery. And I worked there, and as you have observed, in a postgraduate hospital in New York, and with Douglas Northfield, and did about 7 years of work with them. And then I felt it was time that I branched out on my own. At that time, there was a lot of difficulty with jobs for young neurosurgeons in the United Kingdom. They were training far more than they needed. So every time I went for an appointment, I found that I was number 5 on the list with 4 other locally trained people, at least 2 of whom were redundant anyway. So I thought, well, this is, I suppose if I go on long enough I can get in, but this is a bit of a dead loss. There must be other places in the world. So I got a job as a ship's doctor and literally sailed the world. And every time we came to a harbour, I rushed on shore and said, do you need a neurosurgeon here? And sometimes I got a yes, and sometimes I got a no. The no's were sometimes very strange. In Hong Kong, for example, I went on shore and I saw the professor of surgery there. And I said to him, do you need a neurosurgeon in Hong Kong? He said with surprise in his voice, neurosurgery in Hong Kong? Don't be absurd. There's no neurosurgery in Hong Kong. I sometimes do a few leucotomies and that's all. Well, the practitioners in the town were very welcoming, but I got back on my boat and sailed away again. So eventually I was in touch with a friend of mine with whom I had been in the Air Force and who was working out here, and he said, I think that you should come out here and take a look. So I did so, and it was obvious that there was a lot of work waiting to be done. At that time there was no neurosurgeon between Johannesburg and Cairo, so there was a fairly large field for enterprise. And in those days here in this country we were working what's called the honorary system, as they used to have in the United Kingdom, yes, where you looked after those patients who had no money, and in return were allowed to bring in the patients who could pay. Okay. So that I worked as an honorary consultant at Harari Hospital, which had opened in 1956, and in the hospital here, and in return was allowed to do private practice. So I made my living in private practice and as an honorary basis for 15 years. And at that time, the university medical school had then opened, and John Miners was the professor of surgery at that time. When he decided that he wanted to go back to the United Kingdom, the post became vacant, and I applied for it. Of course, the immediate argument that was put forward was, how can you be a professor of surgery when you're a neurosurgeon? So I was ready for that one, of course. It was the obvious question, and pointed out that general surgery is every bit as much a specialty as neurological surgery. It's now a specialty of thyroids, breast surgery, and abdominal surgery. And the remaining little bits that you and I don't want to be associated with. So they accepted that argument, and I was appointed to the chair of surgery. And I must say, those years since 1972, it was beginning of 1972 that I took over, have really been the happiest of my life. By far the major part of my life has been spent in this country now, of course, and I have enjoyed every bit of it. But being with the university has provided more satisfaction than one obtained purely in private practice. Although working at Harari Hospital has always been a great pleasure.
Professor Levy, you've seen it all from the beginning to now. I will not specifically ask you about the pattern of diseases you see here, but what will be informative to the audience is how has neurosurgery changed from 1956 till now, in your experience in Africa?
Well, as I have heard previous speakers saying, there are some disorders which don't seem to occur here at all. And we have mentioned the cerebello-pontine angle tumor, which really is virtually non-existent. Interestingly enough, there are other more almost psychosomatic disorders, perhaps of the nature of trigeminal neuralgia, which until recently I had never seen any cases at all. Just a few months ago, a surgeon in Dar es Salaam described three cases which looked like trigeminal neuralgia, but I'm not willing to actually make the diagnosis that they were cured by decompression. And recently I've seen two cases here which are, I would call pseudo-trigeminal neuralgia. But that's the nearest that we have got to it, whereas of course it's an exceedingly common condition amongst white people. There's another condition which doesn't seem to exist here, but is obviously common in Europe, and that is syringomyelia. We have seen many cases of enlargement of the cervical cord with the characteristic or semi-characteristic symptomatology as is described in the books. Every case of this that has been operated on and the cord has been opened has been shown to have a neoplasm inside. And I've not seen any cases of true syringomyelia. In fact, I think we've only seen cystic disease in the cord, if I remember correctly, twice in all the time that I have been here, and that's lower down in the cord. That is apart from small cysts associated with neoplasia.
Yes. The other aspect of neurosurgery, which I'm interested in, is hydrocephalus. Your papers on hydrocephalus are one of the earliest written about the disease from this part of the world, and you have experience about the total management of hydrocephalus. Would you like to tell us what difficulties you've had with management of hydrocephalus and how you've tried to circumvent these problems?
Well, at the present time we're undergoing a very agonizing reappraisal of that condition because although we have made big advances, we're not sure how well these patients are doing in the long run. In the early 60s, we didn't have any shunts or anything, so that we simply had to shrug our shoulders and try some rather unsatisfactory procedure like perforation of the floor of the third ventricle or ventriculoperitoneal shunting with rubber tubes and all the sort of things was blocked very rapidly. And so our results were extremely poor. When the new valves were introduced in the early and middle 60s, we rushed to get a supply of them and put in about 80 of them. We then waited a while and then proceeded to analyze our results. And they really were very disappointing. They were disappointing because, of course, we know that a shunt is not a one-off procedure. It's a procedure which requires revision and observation all the time. And we had put them into every patient who seemed, on a from the purely medical, surgical point of view, to warrant such a procedure. And as a result, many of them went long distances away from the hospital to areas where there was no control over them. Well, of course, these eventually blocked, as they all do, and the parents were unable to bring them, or unwilling, or both, to bring them back for treatment. So we found that, in fact, our results were very little better than if we had done nothing. That is to say, those that were going to stabilized anyway. They were a little better in that the people who lived within 30 miles of Harare Hospital, or 30 miles of another hospital that was interested to send them back, or who were well enough off and well enough educated to understand the problem, they came back. For the rest, they did not. So we had, after that, a policy which was very selective, that we would only operate on people who fell into that radius. And I was severely attacked in the British Medical Journal by a doctor from Tanzania who claimed that I was practicing one type of medicine for urban people and another for the rural people, and that this was very reprehensible. Of course, he was absolutely right. I was practicing a different type of medicine for those in town because they could come back. Yes. And those miles away in the country were very unlikely to do so. So I'm afraid I don't like it, didn't like it at the time. We had to be very selective. And we only had a very small supply of expensively produced shunts. So eventually I thought, well, this shunt looks pretty easy. I'm sure I could make this. Yes. So we bought the elastic material and the plastic to block the ends, and we started to play with it and make cuts and juggled about with it until we learned how to make a mock-up of the conventional shunts. I admit that we were using the basic ideas, kind of shunt, kind of valve that they had, but we managed to make up shunts just from a strip of plastic tubing, from an old intravenous needle, and the glue that goes with it. So we were able to make these shunts for $5 or $6, excluding the time of the technician in the department. And we've been using those shunts now since 1984, and we must have put in many hundreds of them. Now, we are very satisfied with the way they work, at least in the first instance. As one is satisfied with every shunt, you put in it's working fine. The question is, how well does the patient do? And we did lose a lot of patients, but lately I have been trying to get the money to get a follow-up clerk who will go into the country and run around and find them, and I think that we can do this. And we have anyway done an extensive written follow-up of the patients whom we have done over just this last year. Yes. And I'm sorry to say that even that is very depressing. A very large number have died. Now the other problem is that we get many patients coming back for blockage at the age of 3 or 4. They've had a long shunt put into the peritoneum, and it's taken that time to come to the surface. But that time it blocks. Well, they come back immediately, we know what's wrong and put in an extra piece. And then we look at the patient, and the patient is always extremely retarded. And sometimes I've said to myself, well, really, did I help this patient? And did I help the family? Here I've given them a very retarded child who takes an awful lot of the parents' time to look after, to the detriment of other children. If I had done nothing on a social basis, wouldn't it have been kinder? Now, this is an extremely difficult problem to settle. It has social, religious, and other overtones to it. But I put it to you, Adelola, that we have, in many cases, simply presented the parents with a vegetable. Now, of course, it's important to know whether the vegetable that we've given them didn't live any longer than it would have anyway. If it didn't live any longer, then there's scarcely any point in doing a shunt.
Yeah, I think it is to your credit that you are able to introduce the Harari valve, and I'd like to tell you that I know my colleagues in Nairobi have been working on this. They've been using your device, and it's helping very, very well. And this is quite a significant contribution to neurosurgery in this part of Africa.
Well, it was meant to be a kind of do-it-yourself thing.
Yes.
We had a stand at a recent conference where we had a man showing people how to make it. It's not our object to make it or make profit out of it, but to demonstrate to anybody who wants to do it, this is how you can do it and it will work.
Apart from this, there are many areas in which you've contributed, and I read extensively about your work, Potter's Neck, the subarachnoid hemorrhages. Are there any of your published works that really stand out that you would like to share with us yourself? It's probably a difficult question, but
well, a thing that is interesting us really is the matter of disc surgery. You spoke earlier about what had I seen and how had neurosurgery changed, and I think that neurosurgery is changing in relation to disc surgery quite a lot. At one time, we saw very few discs, and they were all very seriously disabled. Now, this is undoubtedly partly a function of the difficulty patients had in getting to hospital and getting entry to the health service. And all these discs were big bilateral discs with a ridging and a narrowing of the spinal canal, and some, half a dozen of them presented with paraplegia, which had been present for several months. Now, people are coming, certainly coming earlier. They're certainly coming in very much larger numbers, and interestingly, we are getting discs of a different type. Previously, they were bilateral with ridging, as I have mentioned, and we're still seeing plenty of those, where, as one of our colleagues observed in a meeting the other day, a big decompression is required as well as removal of the disc.
yes.
On the other hand, we're now seeing also those more delicate, if I can use that expression, protrusions which are laterally and on one side only and compressing a nerve root, and which very clearly demonstrates only localized pathology. And we have seen in the last 3 years many more discs than we saw in 8 or 10 years in the past. So this is one of the changing faces of neurological surgery. There's another way which is changing, which I don't understand. At one time we used to see very large numbers of subdural hematomas. If we did 1 or 2 every week, or 7 or 8 a month, that was standard practice for us. And a number of years ago we wanted to do some studies on the oncotic pressure of subdural hematomas, which was quite interesting results. And in a year and a half we had done over 100 of them and got those results. Now subdural hematoma, we see it. I don't think we see it more than once a month, except as part of an acute head injury problem. Chronic subdural hematoma, or subacute hematoma I'm talking about, we don't see that very often, certainly not more than once a month. On the other hand, it's been replaced by subdural and intracranial abscess, but particularly subdural abscess with osteomyelitis of the skull. And we are now seeing enormous numbers of these. And the more we see of them, the more radical I become with them. Many of them appear as a result of frontal sinusitis, but not all. Sometimes they're from a secondary head injury, or a bang on the head, or a depressed fracture, but most of them seem to come from here. And the patients present with pus in the upper eyelid, which somebody has incised, and they've got a swelling up here, and sometimes a frank Pott's puffy tumour of the classical type. They very often do not show any osteomyelitic changes at that stage. And if they're late, of course, they appear with hemiplegia, yes, or with seizures, or both, yes, resulting from a pus in the subdural space. And as I say, the more I see of these, the more radical I become, and we will immediately open those patients and take out every piece of osteomyelitic bone that we can find and explore and clean out the sinuses, either ethmoid or frontal. And then we're looking at the subdural space. Well, if they've got any localizing signs, they've always had an angiogram first, so that we would know whether to open the subdural space or not. If there were anything showing in the subdural space, it would open. And one of the difficulties with that is the fact that the subdural space seems to have no boundaries, or very few. And so the pus can track in all directions. We often see it down the midline, and you may see the anterior cerebral arteries pushed apart by the pus. And drainage of these is very difficult indeed. And it's interesting that I feel now that subdural pus, or intracranial pus, is an indication par excellence for CAT scanning. In this town we have restricted access to CAT scanning, in that every scan has to be paid for individually, and the hospital authorities are very considerate of our needs, because after all they know it enables us to handle many more cases than we would otherwise be able to do. So that they are very generous to us, but nonetheless we respect the fact that there are financial constraints. But I believe that this is an indication par excellence, because not only have we sometimes seen the area of pus that we saw in the angiogram before, but we've seen other small areas elsewhere which were too small to be demonstrated in the face of the larger pathology that was there. And in consequence, of course, our results have been very much better. But it's unbelievable the way subdural pus and osteomyelitis of the skull has replaced subdural hematoma, and I have no explanation for this.
Yeah, I was intrigued because I read the papers written by you and Dr.
Glaser, Franz Glaser, yes, that's right.
When he came, and extensive publication, which is very, very, very instructive, and we don't see this in West Africa. We don't see cases like this, and so your publication on your work on this subdural abscesses quite unique in Africa.
Well, we had intended to make a publication of another of a second series of over 80, but we decided to hold on to this until everybody wants to get it over 100, don't they? Okay, so we decided it won't be very long before we get to that figure at our current rate. I think it may be to some extent seasonal, I'm not sure, but if you asked me to explain what the season was, I wouldn't be able to do it. It was certainly in July and August last year that we had 13 in a month and a half or so. And
a lot.
That's a lot, but why it should be in July and August, I don't know. Maybe it was just chance. Probably was.
We'll wait and see.
Yes.
What about problems of research?
Well, basic research is difficult to do because of the difficulties of getting the appropriate equipment and of technical staff who can do it. But we have done some. For example, many years ago now, we did a project on the lactate concentration of arterial and venous blood in head injuries, with a view to obtaining the seeing if there was a prognostic significance. And our figures showed that we could prognosticate within 75% of the outcome, within 75% of accuracy with regard to the outcome. We wanted to go on then to a myelin basic protein, but we were unable to get the equipment, and an arrangement which we made with an institution in the United Kingdom fell through. We saved several hundred specimens and sent them, but nothing happened. I'm afraid very often when you make an arrangement with somebody somewhere else to do the fine technical work, but it seems to fall through. You've got to be able to
yes.
do it yourself. And it fell through for us, which was very disappointing because I thought that we had something there. We did a project on the oncotic pressure of subdurals, as I mentioned to you,
yes.
and this demonstrated to me, at any rate, that the oncotic pressure has really nothing to do with the enlargement of subdural hematomas. Of the 100 that we examined, 75% had an oncotic pressure which was below that of blood and other tissue fluids, and therefore couldn't possibly be related to it. 25% had one which was above. My belief is that there was some other factor. Now, we wanted to do some electrophoresis work, and we did in fact do it, but the results are not worked out simply because we didn't have the time. But rather amusingly, just to show you how difficult some of this work can be, we decided we would do this project on the electrophoresis of subdural fluid,
Yes.
to see if it could be an exudate rather than just a breakdown of the blood. And we ordered the equipment from the United Kingdom and waited 18 months for it to arrive. And one day, Albert Namayabonde, the chief technician, came into my office and said, "It's arrived." We rushed out and tore open the cases. And he looked at me with his jaw dropping and he said, "They've sent the wrong stuff." So it was another 18 months or 2 years of sending it back before the next stuff arrived. And this is one of the difficult problems. The other difficult problem, of course, is simply the maintenance of the equipment. For example, that oncometer, which was so valuable to us, now has lost its membrane and sundry other things and needs repair. And there's the problem of getting foreign currency to do it. And one wonders, well, aren't there more important things to spend what little foreign currency we have on? So we haven't got it going again, which is unfortunate, really, because I think there was more work to be done with it. So we have managed to do some simple basic work, but it would not be possible to embark on any really difficult biochemical studies, I'm afraid, much though one would like to do them, partly because of that, and as we all know, we're all so busy that it's difficult to find the time. You've got to keep driving yourself on all the time if you're going to get anywhere with it.
Talking about driving ourselves on, I was very interested in one of your publications in the British Medical Journal, which you put out a few years ago. And this dealt with your experiences with the Examiners Board of the Royal College of Surgeons of Edinburgh. After years of experience and years of practice, you decided to present yourself as a candidate for the specialist diploma in neurosurgery of the Royal College of Surgeons of Edinburgh. And I was very, very fascinated by the article you put out in the British Medical Journal. Would you like to comment on this interesting aspect?
Adelola, I've always believed that recertification and or something of that sort is something which the profession should be required to do frequently. After all, we don't allow airline pilots to fly us around Africa or anywhere else without them demonstrating every year that they are fit. And it's every bit as much our responsibility to demonstrate that we are fit to continue to look after people. I therefore felt when the new FRCS in surgical neurology was introduced that since I believed this, that I should take it. And I had been at that time, in any event, contemplating going back to the States and taking my American board exams again. But it was easier to go to the United Kingdom, much cheaper, and in any event, you required, I think, a special negotiation to do the exam again in the States because the neurosurgical boards have not yet started proper recertification. So I went over and offered myself and went over and took the exam. The clinical work, of course, is straightforward. There's no difficulty with that. the real problem is the basic sciences.
Yes.
And I only had 8 weeks in which to prepare myself. I went on that really first-class Neurosurgical Review Course, which is run at the Cook County Hospital in Chicago.
Yes.
And it's a course which I would recommend to every practicing as well as trainee neurosurgeon. They should go on it periodically.
Yes.
I've been on it twice, and it really is excellent. Anyway, I went on this course
It
first.
takes 8 weeks.
No, the course is 10 days.
10 days.
The course is 10 days.
Yes.
It's run at one of the hotels there, and there are several hundred people, and a very, very comprehensive faculty, very intensively run in the true American style,
Yes.
starting at 7:30 in the morning and going on till you can just keep your eyes open at night.
Yes.
And you go back to bed and you start again the following morning.
Yeah.
But every aspect of neurosurgery is dealt with, and it really is first class. So then I went over to the library of the Royal Society of Medicine in London and just sat and flogged the books on the basic sciences. But for a person who's been out of basic sciences for as long as I have, there have been tremendous advances which I didn't appreciate. And in order to be thoroughly au fait with it, I would have needed 3 months, besides which part of the time had to be spent doing some work for the university, interviewing people and so on. So I had my 8 weeks, and then I rather reluctantly, unhappily presented myself to the examination. Well, the examiners were very kind, but they tore me to pieces in the basic sciences. And just between you and me, I wouldn't have passed.
but you did pass.
It was very kind and very considerate of them. They did so. The clinical work, of course, was straightforward. But the basic sciences were very educational to me. And the examination was educational in itself. The basic sciences were educational because it brought me up to date with things that I didn't know about. And there's no doubt in my mind, at any rate, I don't know about the students, there's no doubt in my mind that my teaching has greatly improved as a result of it. There's no doubt in my mind that being on the receiving end of the examination, and I don't deny that I was nervous, it helped me enormously to know what it is like to be a candidate again.
Yes.
And I've often maintained that it would do admirals no harm to be lower deck seamen again, if they ever were, for a couple of years or a period at any rate, to learn exactly what it's like to be below deck. And this did my examination technique a tremendous amount of good. Now I'm thinking, as a result of this, many of our colleagues, particularly in the Association of Surgeons of East Africa, to which I'm an active member, but maybe even in the Pan-African Association or elsewhere, many of our colleagues are now being involved in examination technique, in examinations of postgraduate candidates where they were never involved before. And I think that perhaps we must try to formulate, at least for those people who don't have much experience of it, and maybe for us oldies too, some guidelines on how this should be done. In Edinburgh, they are introducing the new fellowship, as you know, and they're introducing a whole lot of new examiners and trying to lay down guidelines for them. And I had a letter from the secretary the other day discussing the problem of the candidates and the examiner, and he said, our examiners are instructed neither to show approval nor disgust. Now, I don't agree with that. I think that it's not right to show disgust, because many candidates are extremely nervous. But I do think that smiles and approving nods are helpful to a candidate, and many postgraduates are very nervous indeed. So I didn't agree with him over that. But I think that perhaps, maybe in the Association of Surgeons at our next meeting or sometime, a little forum on the management of a clinical examination, or even an undergraduate, a preclinical examination, would be valuable to us and to our candidates, and I intend to suggest that to those people who are organizing the next meeting.
What this has demonstrated clearly is the need for continuing education among neurosurgeons. Here we are, we very few, we are miles and miles apart, And if you don't have a system of continuing education, you just fall behind. And I think what we have done is really a sterling example to all of us that there is a need to update. It will not only improve your practice, it will not only improve your knowledge, but at the same time, it will make you a better judge of students, not only at undergraduate level, but even at the postgraduate. And we are now training postgraduate, so we must know what to do. And I think this is another way in which you show leadership. I gladly would like to do this myself sometimes, to be able to update. So many things are changing, and the changes are so quick and so vast that we have to keep up to date.
Well, as you know, Adelola, we recently had a meeting of the Pan-African Association of Neurosciences, and when I was organizing the program, I wondered whether we should have there some visiting basic scientist lecturers to speak to us on recent advances in basic sciences. I did, in fact, let it go for two reasons. The first is that we didn't actually have the money to get them. And secondly, it would have involved duplicating the program or doubling up in some way, or perhaps not, pardon me, permitting young people to present papers. And I think that it is extremely important that we, at our meetings, not only present good work, but also give young people the opportunity to present even what may not be terribly good work, as good as we would like. Yes. And yet, it gives them the opportunity to get started. Yes. And in front of critical audiences who will make them improve themselves. So that I didn't like to bring in other people, even though that, I think, would have been a valuable addition.
Well, the next question that we naturally go to now is question of training of personnel for neurosurgery in Africa. When you came, as you said, there was no neurosurgeon between Cairo and Johannesburg. Now we are having a few. What are your thoughts or suggestions for the improvement in personnel in neurological surgery in Africa?
Well, there's no doubt that we do need more neurosurgeons. Whether they are the most important priority at the moment is open to discussion. My thought in this country, in Zimbabwe, for example, that our priority at the present moment is in the development of some more general surgeons, orthopedists, obstetricians, and gynecologists amongst the surgical specialists. And I would rate them in front of my own specialty, looking at the nation's overall needs. But, of course, these general surgeons who are being trained must have a period in neurosurgery, they must have a period in neurology, in thoracic surgery, and so on. So that they are general surgeons in the truest sense, as you say. And this is what our program is at the present time in relation to the M.Med, and I think that's the same situation existing elsewhere in our area. However, we do, of course, need to train a certain number of specialists as well. Now, the thought of many people has been that a person should do the entire M.Med course and then come to his specialty. I don't think that I agree with that at the present time. Now, when I took the American board training, for example, I was required to do 5 years, which 1 year had to be in general surgery. The fact that I took longer was just my own wish. The minimum was to do the 5 years. And I do know that our ministry is very concerned at the thought that before they can have a specialist in plastic surgery, urology, thoracic surgery, neuro, we are making them go through this 5 years. And I'm trying to press our departmental board and the faculty also to introduce specialist diplomas, neurosurgery.
Yes.
Now, I believe that the training should be done in this country, and this is, in Africa. And this is why I've been particularly glad and happy to receive young people from Mozambique, from Zambia, and from Uganda to come here and train, and we've put ourselves out greatly in order to give them a good all-round view of neurological surgery and give them good practice. What I would like to see is that we decide that a person should do a year, 18 months, or maybe 2 years at most in general surgery, but it's not to be abdominal surgery, it's to be general surgery.
Yes.
And then they can come to us for another 3 or at most 4 years. This would mean that we could get people through in 5 or perhaps 6 years. At the present time, our course in general surgery is only 4 years. This is because of our need for general surgery.
Yes.
We are agreed that when we have satisfied that need, we will up it to 5 in order to improve the standard. And we need to have that kind of number going through in that kind of time for people going through in the specialties. Unfortunately, we do not seem to be able to attract young Zimbabweans into the specialty. There is, we have trained or sent off for training or started a lot of people into neurosurgery, but all except 2 have found themselves nice berths elsewhere, in Texas and in Scotland and all over the world in nice places. And only 2 have come back here. One is my colleague, Mr. Makaravo, who did in fact do his training here with us, and then went to the UK for a year, which is good. And to Mr. Adelola, who also trained elsewhere and came here for a period, and the work is still here. But all the others have gone elsewhere. Well, that's just that's the way it is. But I believe myself that training overseas, whether it be in Europe or North America, orients a person very much too much towards high technology.
Yes.
We had a young man who has recently gone and opened a unit for us in Bulawayo, which is the next biggest town in this country, and we're very glad to have started the centre there.
Yes, that's good.
He trained for several years in Belgium, and he had to be with us really for a couple of years, and he admits it himself. He had to be with us here in Harare for a couple of years before he managed to get himself oriented to this kind of work. And of course, when he first came, his answer to every neurological problem was, "Where does the CAT scan go?" And
yes.
if I said, I think we can't get a CAT scan here, I was looked at as though I were depriving the patient and the neurological surgery of the services of something which ought to be immediate. Well, there were limited amounts, and we had to use our judgment as to which one could have the CAT scan and which one, we could handle without it. So he has gone down to Bulawayo and is doing an excellent job down there. But it took him time to adjust himself. I do think that people should train in their local areas and then go overseas. After all, if they train here, then they hear the gospel according to Laurence Levy. And the gospel according to Laurence Levy is not necessarily the true one. I admit that. I'm the first to admit it. There are other ways of doing the thing. And it's important that they do go and see them. So I like them to do their basic work, and then if we can arrange the money for them to go overseas for a year, or if not to overseas, to some other place where they can learn it.
The problem of loss of trained neurosurgeons is not peculiar to Zimbabwe. It's the same thing we have in Nigeria, and the same thing in parts of Africa. But nevertheless, I think we should continue. There will be losses and wastages, but we hope that we have enough coming back to continue with the practice.
I don't know how we're going to attract young Zimbabweans into the profession, into the field at the moment. They have interests in other directions, and I think one of the problems really is that because there are only 2 of us, it appears to be extremely hard work, which it is. So what people are thinking is,
they are frightened by the load of work they see.
That's right. On the other hand, of course, if there were more of us, there wouldn't be so much work.
Are there any messages you would like to pass on to the young next generation of neurosurgeons about our specialty in Africa?
I can only say that although it's been my life's work really here, and it's been very hard, it has been extremely interesting. I would say that if you're the kind of person who doesn't want to have a contest with nature and wants to have it easy, then it really isn't any good coming into neurological surgery. If you're ready for the fight, if you're ready for the fact that many of your results will be bad because of what you start with, but if you're able to get great satisfaction from the cases which do well, then neurosurgery is a field into which you can come and gain enormous satisfaction therefrom. If you said to me, would I do it again? The answer is yes. There are a few mistakes I wouldn't make, but certainly I would do it again and be very happy, and I'm sure that over the next 30 years, neurological surgery is going to go ahead here more and more rapidly, because hospitals are developing and health services are developing, and we have an expertise which is actually underused. People don't realize the vast amount of neurosurgical and neurological work that there is. General physicians don't realize how much neurology there is, and others don't realize how much neurosurgical work. The field is going to expand enormously in the next 20 years, and it requires money and the young people willing to apply themselves.
Thank you very much. The experience we have too in West Africa is that there's now an acceptance of neurosurgery by the community, and I think this has been demonstrated too in other parts of Africa, and I think that is your experience. I've been talking to Professor Laurence Levy of Zimbabwe, and it's a real pleasure and a real privilege to be able to speak with him and to exchange ideas with him on the development and the future of neurosurgery in Africa. He's been through all this, and his vast experience will be of tremendous use, not only to individual neurosurgeons, but for the development of neurological surgery in Africa. Thank you very much.
Thank you very much, Adelola.